All right, let's go ahead and start it. I'm going to say good evening and also good day to all of our colleagues and friends from around the world, specifically to those of you that the time is close to midnight, like in Australia. I'm Professor Dabaja. I'm a professor of radiation oncology at the University of Texas MD Anderson Cancer Center. And it gives me a great pleasure to introduce to you our first ILROG educational webinar. Particularly excited to start this important educational and hopefully quarterly event with having Professor Engert, the chairman of the German Hodgkin study group, with us. We will be also joined by our esteemed speakers and colleagues, Professors Mikhaeel and Wirth. The topic will be to highlight the potential practice changes as we see the results of the HD17 coming out. The meeting will go as follows. There will be an introduction by Professor Yahalom that will follow me right now. Then Dr. Mikhaeel, then Dr. Engert, then Dr. Andrew Wirth, and then we will end up with a discussion and questions and answers at the end of the event. This event will be recorded and we will post it very soon and send you the information about it. And I will promise that I will address all of your questions at the end of this event. And now I will turn it over to Professor Yahalom, the founder and the chairman of ILROG Society.
So good morning, good night, good afternoon, good early morning, California. So just to give a little bit of the background for this dream team session that we have today. So and we know that the COVID situation has also created some good opportunities and good initiative and changing the way we live. But in the middle of it in New York, and we had it very bad following Italy and China, I was thinking what should ILROG do, and I thought that we have the usual three missions, and first is clinical, and we created we had a team that put together the emergency guidelines of how to provide radiation to hematological malignancy patients under the stress of time in our facility and transportation. And this is, as you know, already published in Blood, and I know it's used very, very often. The second thing was to do research that will result from those guidelines. And we have another team of younger people, Gilles and Joanna Young, that are working with many centers to put all the data we are getting together and make sense of it. And the third thing was the education. When we struggled what we are doing with our meetings, we agreed to have another team that is Butena leading together with George Mikhaeel and together with our Australian colleagues. And I appreciate that Andrew is with hard at late, Andrew Wirth, and we will have those webinars, and Butena will say more about the regularity and the topics, but let's start. We have a great team, and again, I want to thank Andreas Engert, as a good friend of ILROG. It's actually an honorary member of ILROG from the very beginning, and we would love to hear the important studies that change how we practice Hodgkin lymphoma. So back to you.
Thank you, Professor Yahalom. Just note that the three presentations we're presenting today are pre-recorded, and we wanted to do that in particular to have a smooth sailing of the seminars. So I will introduce each one of the speakers with a pre-recorded talk, and then, as I said, at the end, we will definitely have a lively discussion and address your questions. Our first speaker is Professor George Mikhaeel. He's a radiation oncologist in King's College London University, and he's a consultant clinical oncologist in Guy's Cancer Center in London. And I will start his presentation right now.
Husseina, we can't hear the audio.
Yeah,
You said you cannot hear the audio?
No, we can see the slides advancing, but there's no audio.
Okay, hold on a second.
Similar in the UK.
Okay, just 1 second. One second. I'm gonna turn it into Beatrice and see if she can show the audio herself. Yeah, it's the same issue. Just 1 second. I'm so sorry about that.
Lymphoma. I hope you can see my slides now.
To save the day.
We heard it for 1 second, Husseina. When it started, we could hear it.
Okay.
I'm going to cover the evolution
okay. Now
Oh, hear it now.
Yeah.
Hear it now.
chemotherapy rate
All right, let's go.
around on the evolution of the treatment for unfavorable early stage lymphoma. So I hope you can see my slides now. I'm going to cover the evolution of combined modality, chemotherapy, radiotherapy, and guided treatment. And there's a number of things that happened over the years. Combined modality treatment moved from wide field radiotherapy to involved field radiotherapy. Chemotherapy
Hussein, I don't hear again.
Okay, I know what the problem is. We have to mute everyone because there is a background noise with people going on with their life. So if we have to all hear it, unfortunately, we have to be in a quiet area and listening to what's happening. So we're gonna unmute you all and hope that you will decrease your background noise. And then we're gonna start again.
Evolution of the treatment for unfavorable early stage lymphoma. I hope you can see my slides now. I'm going to cover the evolution of combined modality, chemotherapy, radiotherapy, and PET-guided treatment. And there's a number of things that happened over the years. Combined modality treatment moved from wide field radiotherapy to involved field radiotherapy. Chemotherapy moved on from full course of ABVD to tailoring the number of cycles to individual prognosis, then addition of BCOP, and then BCOP ABVD combinations. Radiotherapy volumes have changed, dose has changed, and the techniques have changed. More recently, PET-guided treatment tested the omission of radiotherapy and the escalation of ABVD to BCOP. So we ended up with a large list of treatment options, as you might see here on this table, with the studies corresponding to these options. So there's options started with ABVD, including radiotherapy, based on the HD11 and 14, or the H10 RTC study, starting with ABVD, but escalating radiotherapy for the PET positives, and then adding radiotherapy. Within the H10, there's also of not giving radiotherapy, but giving more chemotherapy to 6 cycles. The rapid is really put here in for the sake of completion, but it doesn't really apply very much to unfavorable group, and I will come to that later. Then the 2 German studies, the HD14 started with escalated BCOP 2, ABVD 2, the radiotherapy, and then what we will hear today about from our guest speaker on the HD17, and again Stanford 5 for the sake of completion. So a large list of options. But starting from historical background, glorious history of the German Hodgkin study group, we can see here as early as the HD5, this was a study testing 2 different strengths of chemotherapy, showing better if you're using combined modality treatment. And the combined modality treatment here included extended field radiotherapy. More importantly, the following study, the HD8, asked a very important question, is within a combined modality treatment, do you need to irradiate sites that are not involved? And the conclusion was that involved field radiotherapy is enough if we've given chemotherapy. So that moved the field significantly forward. Following that, the HD11 looked at comparison between ABVD and BCOP baseline, and then a second comparison of those for between 30 gray and 20 gray. And 20 gray has been shown to be effective in early favorable disease, so that's a good reason to test it here. And the outcome showed that for the radiotherapy 20 gray and ABVD, this was an inferior arm in terms of outcome. So it showed that 20 gray is not enough if we've given ABVD for this group. And that's an important principle in terms of the interaction between the strength of chemotherapy and the contribution of radiotherapy. The winner arm in this was the ABVD times 4 plus 30 gray, because it wasn't any worse than the more intensive chemotherapy and less toxic. So in the HD14, this arm was taken forward, ABVD times 4, and randomized against a combination of BCOP escalated and an ABVD 2 cycles each. And on this comparison, the intensive chemo came up slightly better than the ABVD 30 gray, but the difference is not huge. And then the HD17 asked a subsequent question, which is taking this chemotherapy backbone, again asking if we could give radiotherapy with a PET-guided policy. And we'll hear about that from our guest speaker, Dr. Engert, later. So moving on to the H10, which is an important study, but slightly complicated. They had a favorable group and an unfavorable group. And in each, they had a standard arm, which has no influence by PET, but slight difference in the number of cycles. And then they had a PET-guided arm. For the favorable group, it was 2 ABVD for the PET negative, and escalation to BCOP for the PET positive, and the PET negative radiotherapy was not given. This is our topic today, the unfavorable group, and the PET-guided arm here had 4 ABVD and no radiotherapy. So it's very important to notice that they compensated for the lack of radiotherapy with 2 additional cycles of ABVD, and that's another 100 milligram of idromycin. And then the PET positives were escalated to 2 BCOP and radiotherapy. On interim analysis, the no radiotherapy arms were stopped, and the analysis of this PET negative arm with no radiotherapy is there. So just to remind ourselves, 3 ABVD plus radiotherapy versus 4 ABVD in the early favorable, big difference. And then in the early unfavorable, smaller difference, but there's a difference in the chemotherapy given here. And then the result of the escalation, those who were PET positive escalated then to BCOP escalated, and the result of that was again significant. This is PFS for the 2 favorable, unfavorable together, and this is the overall survival. So moving on to the RATHL, and the RATHL was mainly an advanced stage study, but included 42% stage 2 patients. And it was a PET-guided policy, so PET negatives after 2 cycles were randomized to dropping bleomycin, and the PET positives were escalated with no randomization. So the answer to that was that the bleomycin escalation omission was not significantly different, and the outcome of the PET positive escalation was not, in my view, wasn't very impressive. Overall, the outcome of the whole group in all arms was 82.6% 3-year PFS. The RATHL study here, I mean the RAPID study is again for the sake of completion, but just I'd like to highlight that this was 102A, no B symptoms allowed, and no bulk allowed. And when you look at the study, 2/3 of the patients were early favorable. So it's difficult to apply this to the early unfavorable because they were not the majority, but it was a simple PET-guided randomization into radiotherapy or not, and there was a difference between the radiotherapy and no radiotherapy in favor of radiotherapy. So putting this all together here, if we look at the outcomes now displayed, reported in individual studies, there are 2 points to make here, that they're not very different. So if we take the top one, we'll hear about the HD17 today. If we take the top one on this list, it's the HD15. But this is not very different behind. That's the H10 approach. And the difference in treatment is 100% of patients here receive BCOP, 25% of patients here would receive BCOP with this policy. Now, behind that, very closely behind, is the original HD11 and 14 with 89.1% PFS, and again the HD10 no radiotherapy arm, similar outcome here. The difference again here is 200 milligram idromycin plus 30 gray, here is 300 milligram idromycin. So the question really is, in the individual patient, which is better, more idromycin or radiotherapy in the particular case? So I would suggest, based on this, that the treatments are reasonably comparable, and it becomes not a choice of treatment, but a choice of toxicity, in other words. But the important thing, so this is just to show that we have different options in our own center, so we can use a PET-guided policy, escalate the PET positive severe COP. If someone is not suitable for escalation, we stick to the standard ABVD4 plus radiotherapy. If radiotherapy is not desirable, we go to 6 cycles of ABVD, and we'll see if this may change following HD17. So on the other part of my talk is talking about how radiotherapy itself have changed over time. And the point I want to make is that the problem we're having now is these studies started 15 years ago or so, and a lot of them were really based on the mantle and total nodal irradiation data, producing significant late effects. And therefore, the philosophy has always been trying to avoid radiotherapy. But we do not think of surgery as we're looking at this picture from our museum, our hospital museum. This is a picture of amputation before anesthesia. If we think about surgery nowadays, we think about surgery this way, very advanced, very high tech. So radiotherapy has changed, and that's something that we need to remember in our choice of treatments. This is the HD8, and one of the important key studies that moved the field from total nodal irradiation to involved field radiotherapy, and the first author was Dr. Engert. And the problem with mantle field is this: if you had radiotherapy, if you had a disease confined to one area, in the old days, you treated the whole mantle field. Plot that on the surface of the patient, you can see how much breast is treated and how much mediastinum is treated. If the para-aortic or spleen were added, you can see that the whole heart was nearly covered. So things have moved on. So we moved on from total nodal irradiation to mantle, to involved field radiotherapy, to involved site radiotherapy. And the doses have moved on again from 30 to 45 calculated in a primitive way into 20 to 30 gray calculated in a very sophisticated way with 3D planning and CT planning. And ILROG has been, since 2004, publishing various guidelines describing involved site modern radiotherapy. And more recently, we have 3 guidelines in the last 12 months or so on imaging, contouring atlas, and this has just come out recently describing how do you apply ISRT in various clinical scenarios. Just moving on to one of the technological advances for mediastinal radiotherapy, for example, is treating people in breath hold. And the picture speaks for itself. This is a free breathing view. This is a DIBH view. We can see the lung is expanded more. The heart is very different and moved down. If you look at that in the axial views here, for example, you see a significant movement of the diaphragm. I mean, this is an extreme case, I admit, but it shows the point. And the heart is thinner and moves down. The chest wall is out here. The mediastinum, where the target is thinner. The breast sometimes moves out as well. So it helps us sometimes separate the target, which we see in red here, from the heart, which we see in pink. And you can see then that overlap turned into that window here, and significantly lower dose to the heart with this simple maneuver. In our center, we use a butterfly VMAT arc arrangement, and the idea is we do not treat through the breast or the lateral lung. We use a combination of partial arcs that goes in 8 different directions, and it produces this butterfly dose distribution here, avoiding the breast, avoiding the lateral lung, but still able to offer some heart. And if you put that in context in terms of how does this affect the risk, this is the breast cancer risk in a female age 20 and age 30. This is mantle to 35 gray. This is the radiotherapy, no radiotherapy risk. And you can just see by reducing this to IFRT, you reduce the risk by 2/3. And if you reduce the dose a bit, you reduce it even further. So things have moved on significantly. On the heart, there's a similar effect. This is the dose response for coronary artery disease. And mantle was operating around that level here, and modern radiotherapy operates around that level here. Even if you look at heart failure or heart disease, you see similar level of risk with modern radiotherapy. So what about the risk from chemotherapy? This study is interesting because it looked at data from the ERTC treated patients in various trials and tried to correlate the risk from chemotherapy and radiotherapy, and concluded that a mean hard dose of 5 gray produces a similar excess risk to anthracycline dose of 50 milligram per meter squared. And that's one cycle of ABVD. And considering that what we're talking about earlier now, that ISRT really operates around that level here, there's almost one cycle of ABVD. So the risk of the dose and the volume to the breast, heart, and lungs have reduced with modern treatment, and therefore the risk of second malignancy and cardiotoxicity is expected to be significantly less. And the question really is, has the risk from chemotherapy reduced? Because it's important not to lose the benefit of the reduced risk from radiotherapy to more chemotherapy. And I'll stop there.
Thank you, Professor Mikhaeel. Now I'm gonna move on to our guest speaker, Professor Engert, that we also pre-recorded his message, and we are so honored that he joined us for this first event. And he is also putting up with all the steep learning curve that we're going through to record this webinar. Now we go to Professor Engert.
It's my pleasure to see you and to have this session today on our HD17 trial. These are the final results of this trial. So it's a PET-guided omission of radiotherapy in early unfavorable Hodgkin's. You know that our group has run quite a number of trials with the first 3 generations being handled by Volker, and then there were many other trials. These are sort of phase 3 trials, and you can clearly see that over these years, the number of patients has really increased, and right now we are in excess of 20,000 patients altogether in phase 3. This trial here is one of the more relevant ones. That's HD7, early favorable. And at that time, this was maybe 15 years ago or so, at that time, we randomized radiotherapy only against a combination of ABVD plus extended field radiotherapy. And you can clearly see there's a quite substantial difference, in excess of 20%, favoring the combination of AVD plus extended field radiotherapy. And you can clearly see the differences here with this slide. So one of our follow-up studies is the HD14 study. This study had used ABVD, 4 cycles of ABVD plus radiation. And we had at that time a new combination using BCOP escalated 2 cycles plus 2 cycles of ABVD. And the difference at 10 years in terms of PFS was 5.6%. So that then resulted in this combination 2 plus 2, 2 cycles of BCOP escalated, 2 cycles of ABVD, being more effective and becoming our standard from then on. The follow-up trial is the trial we are discussing here today, mainly, and that's HD17, also early unfavorable. Here we had 2 plus 2. This combination had some more hematotoxicity and infections when compared to 4 cycles of AVD plus radiotherapy. Treatment-related mortality or second malignancies were not different though. The combination of 2+2 plus additional 30 gray involved field radiotherapy thus became standard of care for early unfavorable in our hands. A matter of concern for combined modality treatment were late side effects due to radiation. And it is known that radiotherapy cannot be reduced without loss of tumor control when ABVD serves as a backbone. This is the trial hypothesis and objectives. We thought a more effective 2+2 regimen might allow removing radiotherapy from combined modality treatment. Individualized approaches for patients responding to systemic treatment will determine by PET after 4 cycles. The primary objectives are shown here. This is the first primary objective, is an individualized treatment strategy using PET-guided radiotherapy after 2+2 non-inferior to the standard combined modality treatment. The sensitivity objective, can radiotherapy be omitted from or after chemotherapy from standard combined modality treatment without relevant loss of tumor control in PET-negative patients? And the second primary objective, does a positive PET after completion of chemotherapy represent a risk factor for PFS among patients treated with standard combined modality treatment? That's the trial design of HD17. So 2+2 is the chemotherapy backbone of that regimen. And we discussed in length how to sort of develop this trial. We decided to divide this into PET negative and into PET positive patients, and then no radiotherapy or radiotherapy, 2 different versions. Here you see the patient flow. We included a total of 1,100 patients over about 5 years. In the standard arm, there were 548 patients and 552 in the PET-guided arm. In the intention to treat, we had 546 or 550. Panel review after chemotherapy, 486. 67 of those were PET negative, or 493, of which 68 were PET negative. A protocol, we had 428 or 477 patients in HD17. Here are the patient characteristics. There were no differences in patient characteristics compared to HD14. There were also no differences between standard and PET-guided groups for age, sex, Ann Arbor stage. You see the different Ann Arbor stages here. German Hodgkin study group, risk factors, performance status, and histology. The vast majority of patients had nodular sclerosis followed by mixed cellularity. Now let's look at the first primary objective, and that is, the question is an individualized treatment using PET-guided radiotherapy after 2+2 non-inferior standard combined modality treatment. And endpoints where non-inferiority will be tested for the difference in 5-year PFS between standard arm A and PET-guided arm B. Non-inferiority of the PET-guided arm will be established if the non-inferiority margin of 8% is excluded from the 95% confidence interval. Now here is the PET-guided treatment non-inferiority, and here you see arm A, 97.3 or 95.1. So the difference here is non-significant, that's 2.2%, and you can clearly see that there is no difference between these arms, and with the 900 patients altogether. The median observation time was 46 months, and non-inferiority can be concluded from this data. Let's look at the second primary objective. Question is, does the positive PET after completion of chemotherapy represent a risk factor for PFS among patients treated with standard combined modality treatment? Endpoints, comparison of PFS curves for PET positive patients. This includes arms A and B versus PET negative patients, and that is only arm A, and all patients had received combined modality treatment. Here's the intention to treat analysis, and here's the hypothesis tests. I don't want to go into too much detail here into the statistics. Now, this is the next one. That's PET positivity. Is that a risk factor for PFS? And here you see PET negative patients. The PFS is 97.6. And for PET positive patients, it's 94.2. And the hazard ratio is 303. So clearly, there is no major difference between these two curves. This is the prognosis per DeVille score. It's 5 years PFS, and here you see the DeVille score of 3. That shows us 97.6%. DeVille score, DeVille score smaller than 3, and here this is DeVille score of 3. Also very similar outcomes, 98.8. No difference between DeVille score less than 3 or 3. However, if we compare this with DeVille score 4, you can clearly see that there is substantial and significant difference between DeVille score 3 or less as compared to DeVille score 4. So I think that is a very important finding. And here you see the overall survival, attention to treat. Here again, we have arm A with 98.8. That's overall survival. Or arm B, 98.4. Overall, from this trial with nearly 1,100 patients, we had only 10 fatal outcomes, 4 in arm A and 6 in arm B. You can see here the reasons why these were fatal outcomes. So here you see the curves, very, very much similar. So Hodgkin treated related mortality rates were very low altogether, and the median observation time was 47 months altogether. This brings me to the summary and conclusions of this presentation on HD17. A positive PET of 4 or higher indicates a relevant risk for treatment failure, and that PFS at 5 years, in this case, would be 82%. However, only few patients belong to this high-risk group, 16% in this trial HD17. PET-guided treatment of early-stage Hodgkin, unfavorable Hodgkin's, using the 2+2 backbone is non-inferior to combined modality treatment with 2+2 and 30-gray consolidation radiotherapy. The vast majority of early-stage unfavorable Hodgkin patients can be treated with the highly effective 2+2 chemotherapy alone. PET-guided 2+2 has no relevant Hodgkin or treatment-related mortality and thus achieves 5-year overall, not differing from the German normal population. I think that's a very interesting and impressive finding. So overall, we have to conclude that PET-guided 2+2 chemotherapy is the new German Hodgkin study group standard of care. And many patient people contributed. This might be a little bit difficult to see, but we also have different groups of doctors contributing. That is pathology, radiotherapy, and that's why we are based here in the medicine laboratory, other physicians, and so forth. And this is our trial coordinating center with many other people, statisticians, for instance, contribute. And with this, I thank you very much for your attention.
So welcome, everyone.
Thank you, Dr. Engert. This is very informative, and we were looking very much into listening to the results. Professor Andrew Wirth, now who's the head of the hematology radiation oncology at Peter MacCallum, will be trying to navigate the complexity and the challenges of how to apply the recent results from the HD17 into our practice. Just a point, it seems that Professor Andrew Wirth will have a lot of bloopers, because while I was recording him, also we ended up with a lot of bloopers. So when we record the webinar, probably we'll include it as a bonus at the end. Thank you. Professor Wirth.
The third presentation of a very exciting webinar, and it's a great pleasure to follow Professor Mikhaeel and Professor Engert. And I'll just hopefully share my screen. So for the next few minutes, I'm going to review some clinical considerations in the treatment of unfavorable early stage Hodgkin lymphoma. And I want to briefly highlight a few key points. Firstly, the definition of unfavorable early stage disease and the heterogeneity of that entity, the importance of disease burden in prognosis, the importance of disease distribution in therapy selection, particularly with respect to radiotherapy, current approaches to treatment as we use, for example, in our institution, and then to speculate briefly about future approaches after HD17. The definition of unfavorable early stage disease is well known. It's stage 1 or 2 with risk factors, but it's important to recognise that there are two types of risk factor. Those that relate to tumour burden, the number of involved nodal regions and the presence of a large mass, and other factors. And this combination of criteria really defines a heterogeneous population. And as we can see from this range of clinical cases illustrated here, the tumour distribution and burden varies enormously within this population. And these factors influence prognosis. They determine the ease of delivery and the safety of radiotherapy, and therefore potentially influence treatment strategy. And these anatomical markers of tumour burden are very important prognostically. And here we can see an analysis from the German Hodgkin's group of prognostic factors within both the German and the EORTC systems. And this highlights the importance of anatomical tumour burden, whereby large mediastinal mass and a large number of areas in both systems were the dominant features from a prognostic point of view. And for example, we can see that age within the EORTC system in this multivariate analysis no longer held prognostic significance. And the other important point is that we have different ways of measuring tumour burden. Both the EORTC and the MD Anderson group have looked at the impact of metabolic tumour volume measured on FDG PET and found it to be a very strong prognostic factor. This slide illustrates results from the EORTC HD retrospective analysis of the impact of MTV, and you can see it dichotomizes the population into two very different prognostic groups, and on multi-analysis the baseline metabolic tumour volume and the interim PET were the only two prognostic factors. And so the investigators in this study were able to define 4 prognostic groups based on just these 2 criteria, baseline MTV and interim PET. And in particular, patients with interim PET negativity and a low baseline metabolic tumour volume had a 5-year progression-free survival of 95%. So this is a very useful way of identifying patients' prognosis. So what do we think about when we select the initial treatment for patients in tumour board discussions or in the clinic? Firstly, we consider the prognostic features, some of which I've alluded to. Secondly, we consider the patient's fitness for ABVD or more intensive chemotherapy, considering age, comorbidities and fertility considerations. And finally, we look at patients' suitability for radiotherapy. Age, sex, smoking history and comorbidities may affect anticipated toxicity. And we look at the ability to safely encompass all sites of disease, or in some settings, all bulky sites of disease for a given patient. And it's possible to usefully think about patients within 3 broad clinical presentations. The first group are patients with limited extent of disease, where all of the initial disease can be safely encompassed in a radiotherapy volume. We have just 3 examples here. We have 3 patients with upper mediastinal and cervical disease, and in this case, bulky cervical disease, who are in the unfavorable group by virtue of age or B symptoms. For these patients, radiation can be delivered with no coronary and no myocardial exposure, and no or minimal breast and lung exposure. So for this group of patients, 4 cycles of ABVD and a 30 gray is an effective and low-risk strategy. The second group of patients are those who present with more extensive disease, but with a dominant mass. So here you can see a young woman with stage 2B bulky disease, with a large upper mediastinal mass, but small volume deposits throughout the mediastinum. And we can see that the large mass tapers off and ends above the level of the coronary artery, with multiple small deposits circumferentially around the heart. For presentations such as this, we can't safely encompass all sites with radiation, but we could safely treat the bulky mass with minimal organ exposure. So for such presentations, 6 cycles of ABVD to treat all of the disease with radiation to the high-risk bulky site is one important strategy. And other clinicians and other centres will use chemotherapy alone for these presentations, a la the rattle trial or the HD17 approach. The third group of patients are those with extensive disease with no dominant site. So here you can see a patient on axial imaging with neck disease, subpectoral disease, upper mediastinal disease, and small deposits or medium-sized deposits of disease circumferentially all the way around the heart, all the way down to the diaphragm. So for these patients, it's challenging, if not impossible, to safely irradiate all sites, and we can't define a dominant bulky site, and these patients are generally treated with chemotherapy alone. In practice, as we are all aware, patients don't always fall neatly into one of these 3 categories. So for each patient, we have to carefully consider the benefits and risks of radiation versus the benefits and risks of the intensification of systemic therapy. And there's often a fine balance in choosing the optimal approach for any given patient. And this needs multidisciplinary discussion and indeed discussion with the patient to elicit their preferences. So what I'd like to do in the last few slides is really just summarise what might be described as a common current approach and then speculate about where we go after HD17. So this approach uses initial ABVD chemotherapy, and we can see that patients have 2 cycles and an interim PET. The vast majority of patients are PET negative. And then we ask the question, can we safely irradiate all initial sites of disease? If we can, the patient fits into group 1, treated with 4 cycles of ABVD and involved site radiation, and we anticipate a 92% cure rate for this population. If we can't irradiate all sites of disease, we may then ask, can we safely irradiate all the bulky component of disease? If we can, we in our centre will often treat with 6 cycles of ABVD and intensify by giving radiation to the initial bulky site. And again, this group has not been well studied prospectively, but we would speculate that the results in this group may be 92% or even higher, given the addition of 2 cycles of chemotherapy. And again, for patients where there's no definable bulky site to target, we do treat these patients with 6 cycles of ABVD and anticipate around a 90% cure, a la the H10 study or the RATTLE trial. The small group of patients who are PET positive can then be, if they're fit and suitable, can be escalated to BIACOP and the involved site radiation, again with about a 90% cure rate. And I think the operative issue for all of these decisions are the questions: what is a safely irradiated volume? And what does it mean to adequately cover the initial bulk disease? Radiation oncologists love to argue about these questions, and really to explore this in detail would require a whole lecture of its own. So where do we go now after the results of HD17? Well, I think the first group where we would clearly want to consider the more intensive therapy are those patients in what I call group 3, currently treating with ABVD alone. For this population, we should assess whether patients are fit and whether the toxicity risks of escalated BIACOP are acceptable, and if they are, the HD17 strategy is very appropriate and with a very high cure rate. If those risks are not acceptable, we would again go back to treating with ABVD with or without radiation, with somewhat lower cure rate, but still a very respectable outcome. Perhaps being a little bit more speculative, we could approach patients this way. We could dichotomize patients based on their baseline metabolic tumor volume. Those who have a low volume and can come down this pathway, if we can safely irradiate all sites, 4 cycles of ABVD with involved site radiation is appropriate, and if we can't, 6 cycles of ABVD with or without radiation. And based on the analysis of the ERTC H10 study, we may now anticipate a 95% progression-free survival based on the low initial MTV and PET negativity at interim assessment. For patients with a high baseline metabolic tumour volume, if they're fit, again, the more intensive chemotherapy may be very appropriate and with excellent outcomes. And if not, the more conventional approach of ABVD with or without radiation may be considered. But again, because of the high metabolic tumour volume, we may anticipate a slightly less satisfactory outcome in this group. So to summarise, unfavourable early stage Hodgkin lymphoma is a very heterogeneous group of patients. PET-guided ABVD with or without radiation has been the backbone of management for many years. Escalated BIACOP and ABVD is now an important, effective treatment option, and it all comes down to wise treatment selection, exploiting both conventional and emerging prognostic factors, and looking carefully at the balanced efficacy and toxicity of each of the competing strategies. And I thank you for your attention.
All right, now we heard from our 3 speakers, and in the meantime, I received a few questions. I will start with the first one, which was addressed to Professor Engert. We're gonna display the audiences right now. The first question to Professor Engert from Dr. Shakir is that first, she would like to thank you for the summary of HD17. Hugely helpful. She said, I'm interested to hear about what Professor Engert thinks about the potential for late toxicity with the 2+2 regimen. We only have a 47 months median follow-up. Is there not a potential for higher longer-term risk from BIACOP, which might exceed that expected from modern radiotherapy?
This is a very good question, actually. And yes, we discussed the impact of 2+2 substantially over a long period of time. But so far, we've seen that many patients profit really from this chemotherapy, from this more aggressive chemotherapy. However, if we look into the future, we might be able to use checkpoint inhibitors, for instance, in order to cut down on the chemotherapy. That's not only true for early unfavorable, that's also true for advanced stage patients. And we hope that with the checkpoint inhibitors, the toxicity can be further reduced.
All right, thank you. Another question, it would be for you and probably for Dr. Wirth. I'll start with you, Professor Engert. What is your current definition of bulky disease?
Well, the definition of bulky disease is a third of the diameter.
So you're still using a chest X-ray?
Yes.
Okay, what would you say to the many institutions that are now moving towards using a CT of the chest? And one, it's so timely right now, and I'm happy that Dr. Hoppe is on the call. Part of the NCCN guidelines, we meet for the Hodgkin lymphoma guidelines, and that was one of the discussions that it came from many American institutions that why do we still need the chest X-ray and why not to delete it from the guidelines altogether since we all use a CT of the chest? So I would be interested in your opinion and if Dr. Hoppe has a comment on that.
Yeah, I think normally it's the chest ray, what we are still using in many groups and hospitals, because they want to save money, but certainly the CT scan is more precise, and this is what is being used in more and more hospitals, smaller hospitals too.
Okay. Dr. Hoppe, do you?
Yeah, so as you know, a lot of our historical data is based on the chest X-ray, and that's obviously how patients are triaged on the German Hodgkin study group trials and also the EORTC trials. And so if we try to follow those trials, we need to get a chest X-ray. I think there's also other value to a chest X-ray in following patients. If there is a concern about disease in the chest, one may be able to avoid doing repeated CT scans in certain circumstances by just getting a simple chest X-ray, which has very little X-ray exposure. So I wouldn't throw chest X-ray out the window.
Okay, I think Dr. Mikhaeel wants to make a comment, and I see Dr. Advani on the call too, if she would like to make a comment.
Yes, thank you, Buthaina. My comment really is that a matter of, as a point of principle, there is a difference between defining bulk for the purpose of radiotherapy benefit and defining bulk for the purpose of prognostication as part of an index or a criteria. So I think that what we are answering now is the German Hodgkin study group definition of 1/3 of the chest. But when you start looking at things like the analysis of the rapid study in the no radiotherapy arm and the size effect on relapse without radiotherapy, 5 centimeter came as a significant cutoff for increased risk of relapse. There is data from Memorial Sloan Kettering suggesting 7 centimeter in a similar way, both are early Hodgkin's lymphoma. The Italian studies looking at randomization of advanced stage used the 5 centimeter cutoff. I think the other point is anywhere between 5 and 10 is likely to be significant because it's a linear relationship, and it doesn't matter where you draw a cutoff or you put a cutoff. It's a linear relationship probably between 5 and 10 centimeter. But it's a question of, are you just looking at prognosis or are you looking at defining benefit from radiotherapy?
I'm not sure if Dr. Advani is still on the call and if she would like to. Okay, great.
I am here. The concern I have getting rid of chest X-rays, often when you get the CT report, they're not really measuring, they measure individual representative nodes in the mediastinum. And often it underrepresents the bulk. And when you have a chest X-ray, you actually capture that better, or at least then can challenge the nuclear medicine colleagues to give us a broader measurement. And the other question I have is, this is all about mediastinal bulk. What about bulk like, big 10 centimeter mass in the neck? How do you account for that? I mean, that's the CT measurement. versus a chest X-ray for mediastinal bulk.
And actually, that was one of the questions that came from Dr. Rabinovich, which is if you have a neck mass, then how do you measure it and what's considered bulk? And we should remember that our colleagues in Memorial Sloan Kettering did publish their paper, and I think they landed on a 7 centimeter when it comes to the neck mediastinum. Am I right about that?
Yes, Butana, you're right, but the measurements were in more than one dimension. And if we have one dimension more than 7 centimeters, of course, we went through all the different sizes. It came out at least very clear that patient treated with chemotherapy alone, 7 centimeters was the cutoff point for a significantly inferior outcome. Whether less than 7 centimeters, but again, retrospectively, the outcome was similar for chemotherapy alone and for combined modality in a variety of regimens.
Okay, great. I have a question also from Dr. Phoenix, who mentioned, in light of the EORTC HT results, has the panel modified their approach to the utilization of consolidative ISRT for early stage unfavorable patients? The H10 favorable hazard ratio was clearly in favor of RT, roughly 16, but for the unfavorable trial, the hazard ratio was only 1.45 in favor of RT. Therefore, one more oncologist comfortable offering 6 of ABVD alone in lieu of 4 ABVD and RT as in this trial, question mark. In light of this data, I find myself struggling more with qualifying the benefit of RT in this patient population. I think Dr. Phoenix can unmute herself and ask Dr. Engert the question in a simple statement if she would like.
Sorry, it took myself a second to unmute. Yeah, this question also is for the panel, and Dr. Wirth kind of touched on this a bit in terms of the heterogeneity in the early stage unfavorable population. But I was just wondering that, you know, in light of the H10 unfavorable trial results where we see, when we compare the 6 of ABVD alone to 4 in radiation, the benefit is definitely not as pronounced as we saw in the favorable population, suggesting somehow in this patient population that those extra 2 cycles of ABVD can perhaps compensate better for radiation as opposed to the favorable study where 1 cycle of ABVD didn't do such a great job substituting for involved sites. So I guess I'm just wondering from the panel, has this trial modified your approach in how you counsel patients on the potential benefit of ISRT, and are you more likely to agree with 6 cycles of ABVD alone without consolidation?
Mike, shall I comment? I think the study does give us pause to think about how we approach these patients, because for a benefit of a couple of percentage points, we have to be careful in exposing patients to radiotherapy. So I think this is, in my perspective, this is where the heterogeneity becomes very important. Unfavorable early stage disease can be a patient with a 12 centimetre upper mediastinal mass, or it can be a patient with multiple sites of disease throughout the mediastinum and axillae and B symptoms. And I think it's very plausible and it's rational to assume that the role of radiation in improving control will be very different. So it may be that 2%, 2.5% we're seeing in the unfavorable population reflects somehow an averaging out of a population with bulk who may be benefiting more than that, and another population who may not be benefiting at all. So that, I've not seen that fully teased out in any data set. So
I'll make a couple of comments in response.
Yeah, 1 second, George. I needed Andrew to answer 2 more questions that came to me. The first one is, what do you mean by dominant mass? And would you use, they asked you, although I think this question would have been better suited for Dr. Engert, would you use escalated BIACOP to save avoid gonadal toxicity?
So I'll pass on the second
dominant mass.
With a dominant mass, it's not been rigorously defined, so it's a clinical judgment. I guess conceptually, you're trying to identify patients for whom you can treat the vast majority of the initial disease burden while sparing critical organs. So it's a concept that I've developed and that many of us utilize in our clinical practice to decide whether to try and use radiation in patients with unfavorable disease. But I have to state very clearly, it hasn't been studied in a rigorous fashion. It's a clinical judgment.
Okay, so I'm sorry, George, I'll come back to you. I just want to make sure that I would answer the audience's question. So 2 questions to Dr. Engert. The first one is about the gonadal toxicity of escalated BIACOP, and another question that came to you about elderly patients or frail patients when BIACOP is not possible. What would be your next step in these cases?
Yeah, these are 2 very interesting questions, actually. The late toxicity with BIACOP escalated is certainly higher as compared to ABVD. It is obvious, so that patients older than 60 or patients with, let's say, lung problems, prior lung problems or so forth, this would not be candidates for BIACOP escalated. I mean, BIACOP escalated was developed for the advanced stage patients. So in the beginning, they received 8 cycles of BIACOP escalated. That went then down to 6 or now to 4 in the advanced stage patients. In the early favorable, it's just 2. But still, we would be sort of careful if this would be frail patients or patients who are sort of older than 60 years. Certainly, patients between 50 and 60, we would be very careful to sort of treat them with BIACOP escalated.
So what you're saying is that in this age group, let's say you have a 65-year-old, what would be the regimen that you would give?
ABVD.
Okay, perfect. Dr. Specht asked, 2 extra cycles of ABVD may well be more toxic than radiotherapy with regard to cardiotoxicity. What would you say about that, Professor Engert?
That's difficult to tell. It has to do with the size of the tumor and the activity of the tumor and so forth. So I would think that the combination of chemo and radiotherapy is most often the choice we would pick.
All right, thank you. And the last question is for the US medical oncologist, anybody would be free to answer. What is the hesitancy in using BIACOP in the US in general? I think Dr. Advani does use BIACOP, but if anybody would like to comment on that?
I think the academic centers are comfortable using it. It's the community which is scared. I mean, just like they don't do dose-adjusted epoch in the community. But I do think that for the right patient in the academic setting, we are all comfortable using it. I certainly have used it a fair amount.
Okay, thank you. Yes,
I may comment about
I have a quick question also about Dr. Andreas's comment that over 65, he would use ABVD over BIACOP. In the US, on our recent NCCN call, we heard some very strong concern about bleomycin in anyone over 60. And I would be interested in knowing in Europe what the practice is in that situation.
Ranjana, you took the questions from my mouth.
I'm sorry.
That's awesome. Okay, good.
It's really a serious issue. And we realized in NCCN discussion that we don't have really a consensus, and because we don't have good data on the elderly patients that we see more and more.
Okay, go ahead, Professor Engert.
Yeah, I think so there's no aggressive chemotherapy beyond 60 years. So all these patients would receive ABVD or AVD because bleomycin is also very toxic and does not really contribute to most of the response. So that's why we are, and there is, you probably know, there is a randomized trial from our British friends showing that bleomycin has little, if any, impact on the outcomes. So that's why we are more and more hesitant using bleomycin, and that's also particularly true for elderly patients. So we would not use bleomycin in elderly patients anymore at all, if possible.
Is whether radiation therapy will have more of a role and should be used more often in the patients that receive somewhat modified chemotherapy, and we don't have the answer for that. We just think that it will.
Okay. I don't have any further questions. I'm going to go back to Dr. Mikhaeel. He had few comments.
My comment was on Chelsea's question, because it's really the clinical question that comes up in every tumor board discussion. So although they seem the early unfavorable 6 cycles ABVD versus 4+ radiotherapy seem very similar in outcome, I consider them 2 choices depending on toxicity. So it's back again to we're choosing for toxicity. I think Lena made the point very well that sometimes you look at the distribution and you see that you will not irradiate too much heart, and therefore 4 ABVD plus radiotherapy is better than 6 ABVD. I guess where the HD17 will help us in the future is an example is the case that Dr. Wirth showed, where the disease just grows all around the heart, and any of us would want really to avoid radiotherapy for such cases if we can. So using an upfront chemotherapy that reduces the chance of PET positivity and the need for radiotherapy might be an option. So that's the other end of the spectrum, if you like. If you have a very difficult case where you'd like to avoid radiotherapy, I think 2+2 is a very good option to reduce the chance of PET positivity.
Mm-hmm. I actually...
One other comment.
Go ahead. Yeah, go ahead.
I think that with the HD17, I think the fact that we've got another approach is very, very useful. Often in the tumour boards, you see a case presented and you try and make a judgment before you've gone through the process of planning, whether you can reasonably safely give radiation for that case. If you've got a policy of giving everyone ABVD, and you get to the planning point and you realise it's going to be more challenging than you thought, you've committed. So I think that now that we've got a couple of options in terms of chemo, we have to be much smarter at making those evaluations early and recognising patients for whom radiation will be challenging to give safely, and then perhaps in appropriate patients go down the escalated BIACOP approach. So I think it puts a greater onus on us now to recognise those patterns of disease and the safety of radiation, and we don't have the luxury of waiting to the planning phase.
So I have a complex question for Professor Engert, which is about elderly patients, and I think one is coming from Oklahoma University and the other one from Sweden. For Professor Engert, if you have a patient that is an elderly and had an interim PET positive, what would you do if you decided originally to give ABVD and now the PET is positive? And then as a follow-up, in Sweden, the person said that in elderly frail patients, we, although be interested with studies including novel drugs, what about pre-treatment with checkpoint inhibitors in frail elderlies?
Yeah, it really depends on the status of the patient. If the patient is, let's say, 65 years old, but frail, then it is very difficult to treat such a patient with BIACOP escalated. I mean, that's not possible at all. AVD would be a possible treatment for these patients. And certainly we would also talk to you, basically, to the radiation oncologist, in order to, if there is a residual tumor mass in the mediastinum, for instance, we would not sort of just insist of chemotherapy, but asking you to sort of bring in the radiotherapy for these patients. Even that could be a sort of more palliatively orientated treatment.
Mm-hmm. Great, thank you so much. I don't see many questions. Oh, no, there is one came from, I'm guessing Netherlands, yes. We are discussing how to implement the results of HD17, but we would like to be able to read the full publication. When can we expect the paper?
Oh, we're working on it already. So.
Okay, great.
Butena, if I
Yes.
may add to a complete information, I think that we give a lot of credit to the importance to the H10 EORTC unfavorable, but we don't have all the data that we want, because this is we don't understand why the arms are really equal. We expected just like the favorable, perhaps the radiation will have a superior result. But it is a heterogeneous group, so we need perhaps some kind of, even if not allowed, some understanding. But more than that, we need to understand the patterns of relapse. Where did these patients relapse? Is that in the margin of the field because radiation oncologists were not, were concerned with the volume? Is it all distant relapses? I think I will ask Lina to tell us, in order that may be working on it, if this is something that is in the making.
Yes, thank you very much. It is in the making. We were trying to get started on it, and I'll take it up as soon as I get some time for it. It's a very relevant one. Most of the recurrences, if radiotherapy is given, is in completely different areas. So I can't answer the question. We'll try to work on it.
Great, thank you. I don't see any questions coming. I think that was, oh, every time I say that, something comes. What was the survival difference between the two arms in the Duvel 4 groups in HD17? Realize the numbers are very small.
I think the difference were between 10 and 15%. So yeah, very small.
Okay, so you can see, Professor Engert, everybody is so anxious to see the final results and the final manuscripts. And I think I'm gonna end it here, and want to thank the speakers, the audience, everybody who asked questions. I want to remind you that this is going to be recorded, posted on the ILROG website, and maybe on YouTube. We're working on that. Really big thank you to all of you who worked with me, Professor Engert, Professors Wirth and Mikhaeel. It took a lot of preparation, but I'm learning. I think I'm going to be a very good press secretary in the future that will not be fired like so many that happens here. So I want to thank you so much. Thank you, Professor Engert, for honoring us with starting this educational event. I would leave it now to Achi, Lena, George, or Andrew to close.
I will just say, and I'll have other people close, that we plan to have it based, and again, on your responses, comments. We would like to have feedback, but we think right now about doing it quarterly, every 3 months. If we have some outstanding reason, we may do it even more frequently. But I feel, Butena, this was a success, and I think that we will want to continue, and we also want very much to get together, and hopefully we'll have a meeting in person, not before too long.
Great. George?
Just to ask the audience, actually, if they think of any topics they would like covered in future webinars, please email Butena, bdabaja@mdanderson, or myself.
And I have a Twitter account too.
Yeah.
Andrew, and then Lena, and then we'll finish with Professor Engert.
Well, just to say, it was a really great inaugural meeting as an ILROG educational webinar, and I look forward to these on a regular basis.
Can I post your bloopers, Andrew? Okay, Lena.
Well, just thank you very much for organizing this. I think it's a great initiative. In these COVID-19 times, it is really going to help people. So thanks a lot.
Professor Engert. the last word is your word.
Yeah, thank you so much. I enjoyed it very much. And maybe at the next meeting, we will be talking about checkpoint inhibitors in combination with radiotherapy.
Yeah,
so,
that would be great.
Great idea. We have a task force on that.
Great. Thank you so much.
Thank you, everybody. Enjoy the rest of the night and the day for so many of you. Thank you.
Thank you.
Good night.